Good morning. My name is Julie Nongam from Baylor College of Medicine, and one of the hats I wear is I direct our hereditary cancer and breast cancer prevention program.
And I'm Wendy Woodward. I'm the chair of breast radiation oncology at MD Anderson, and we are delighted to open this fourth general session this morning with these very interesting top-scoring abstracts on local regional recurrence, as well as breast cancer risk, low-dose tamoxifen, and pregnancy while pausing endocrine therapy. So it should be an exciting session. And without further ado, I welcome Dr. Judy Boughey to the podium to discuss the impact of breast conservation therapy on local recurrence in patients with multiple ipsilateral breast cancer. These are results from ACOSOG Z11-102.
Thank you very much for the opportunity to present the results of the Z11-102 clinical trial. These are our disclosures. Increasingly in the clinical practice, we are identifying patients at the time of diagnosis that have more than one focus of breast cancer within the breast. This is both as a result of improvements in screening imaging, as well as diagnostic imaging, and an increased use of preoperative breast MRI. Historically, retrospective studies have shown high rates of local recurrence in patients treated with breast-conserving therapy for multiple ipsilateral breast cancer, and this leads many surgeons to recommend mastectomy to this patient cohort. However, more recent institutional retrospective studies have demonstrated acceptable local regional recurrence rates with breast-conserving therapy. This is really due to the vast improvements across the entire spectrum of breast cancer management, not only breast imaging, but also pathologic margin assessment, improvements in targeted and systemic therapy, and radiation techniques. Therefore, we designed the Z11-102 clinical trial as a prospective single-arm phase 2 trial to evaluate breast-conserving therapy for women with 2 or 3 foci of breast cancer in the breast. This study enrolled women aged 40 and over that had 2 or 3 foci of biopsy-proven breast cancer. At least one of these foci had to be invasive disease, and the additional foci could be invasive or DCIS. The protocol required at least 2 centimeters of normal tissue on imaging between the lesions to ensure these were truly separate lesions, and the disease could not occupy more than 2 quadrants of the breast. The study excluded any patients that had any lesion over the size of 5 centimeters, patients with bilateral breast cancer, prior ipsilateral breast cancer, or known deleterious mutation in BRCA1 or 2 gene. Patients were registered to this study and underwent breast-conserving surgery through either a single lumpectomy or multiple lumpectomy approach. Oncoplastic surgery was permitted, and nodal staging was required with either sentinel lymph node surgery or axillary dissection. Patients then went on to protocol-directed radiation therapy, which mandated whole breast radiation with a lumpectomy boost site to all sites of resection. Adjuvant systemic therapy was at the discretion of the treating medical oncologist. However, neoadjuvant therapy of any kind was not permitted. Patients were followed every 6 months until 5 years after the completion of their whole breast radiation. The primary objective of this study was to assess the local recurrence rate in patients with multiple ipsilateral breast cancer treated with breast-conserving therapy. The protocol defined that a clinically acceptable 5-year local recurrence rate would be less than 8%. Several secondary endpoints of the study have already been published. Notably, the 7% rate of conversion to mastectomy due to positive margins, the excellent or good cosmetic outcome at 2 years, which was seen in 70% of patients, and the easy, strong adherence to the protocol-directed radiation, which was not associated with any worse overall cosmesis. Between July 2012 and August of 2016, 270 patients were enrolled in the study across 78 sites. 66 patients, as shown, were not eligible for the primary endpoint, and today we will report on the 204 patients evaluable for this primary endpoint. There was one key amendment in 2015, which allowed the enrollment of patients who had not had a preoperative MRI, which had been previously required by the protocol, and it also allowed post-surgical enrollment of patients who otherwise met study criteria but had already undergone resection. Looking at our patient population enrolled in the study, the mean age was 61. Almost 60% of patients had clinical T1 disease, with 40% having T2 disease. The main tumor biology was ER-positive, HER2-negative, which we'll discuss later, and 77% of patients were pathologic node-negative. 29% of the patient population went on to receive adjuvant chemotherapy. Our median follow-up on this study is 66 months. So now we come to the results. 6 out of the 204 patients have developed local recurrence, 4 in the ipsilateral breast, 1 in the skin of the ipsilateral breast, and 1 in the ipsilateral chest wall. This results in an estimated cumulative incidence of local recurrence at 5 years of 3.1%, and the 95% confidence intervals range from 1.3% to 6.4%, remaining well below the defined 8% clinically significant threshold. In addition to the 6 patients with local recurrence, there have not been any patients with regional recurrence. 6 patients have developed contralateral breast cancer, and 4 patients have developed distant disease. None of the patients have developed both local and distant recurrence simultaneously. 3 patients have developed non-breast cancer new primaries, and of the 8 patients that have died, 1 of these was a breast cancer-related death. Given that only 6 local recurrences, multivariable analysis is not possible, but focusing on univariate analysis, looking at factors that could be associated with local recurrence, we can see here that the vast majority of patients enrolled in this study had 2 foci of biopsy-proven breast cancer, with only 7 patients having 3 foci of disease, and no local recurrences within this small group of 7 patients. As we look at pathologic T category and N category, we can see that with larger tumor size and with node-positive disease, numerically the risk of local recurrence is higher, but that this did not reach statistical significance. Similarly, all patients were required to have negative margins. However, in the subgroup with margins that were less than 2 millimeters, there was a numerically higher but not significantly higher risk of local recurrence. And tumor histology did not impact local recurrence rate. Looking at tumor biology, we classified each patient by the most aggressive tumor biology that they had within the tumors in their breast, classifying ER-negative, HER2-negative as more aggressive than HER2-positive, which in turn was more aggressive than ER-positive, HER2-negative disease. We can see that the vast majority of our patient population, 83.5%, had ER-positive, HER2-negative disease, and the local recurrence rate in this cohort was 2.6%. Of the 23 patients with HER2-positive disease, none of these patients have developed a local recurrence. And in the smallest subgroup, the 10 patients with ER-negative, HER2-negative disease, there has been 1 local recurrence for a 10% local recurrence rate. As I mentioned previously, breast MRI was initially required by protocol, and subsequently in 2015 this was amended. So we had 189 patients that did have a preoperative breast MRI and 15 patients without a preoperative breast MRI. The local recurrences, 3 of these occurred in the group with MRI and 3 occurred in this small group of 15 patients without preoperative breast MRI, resulting in an estimated 5-year local recurrence in the patients without preoperative breast MRI of 22.6%, with a hazard ratio of 13. And while this was statistically significant, we need to bear in mind that this was a secondary unplanned analysis. Focusing on the 195 patients that had at least 1 lesion that was estrogen receptor positive, the vast majority were treated with adjuvant endocrine therapy. However, 20 patients did not receive adjuvant endocrine therapy, and in those without adjuvant endocrine therapy, the estimated local recurrence rate was higher at 12%, and this was statistically significant. And clearly, this study has several limitations. Not only its single-arm study design, since a randomized study was not felt to be feasible, but we also note that there was a small subset of patients that did not have a preoperative MRI. The subset of patients with aggressive tumor biology, such as HER2-positive or ER-negative, HER2-negative disease was small, as was the cohort of patients that had 3 foci of disease within the breast. Furthermore, given that the predominance of our patient population was ER-positive, there is concern that the 5-year follow-up on this protocol may be shorter than needed. In summary, the Z11102 clinical trial demonstrates that for women with multiple ipsilateral breast cancer, breast-conserving surgery followed with adjuvant radiation with boosts to all lumpectomy sites has a low local recurrence rate of 3.1% at 5 years. It's important to note that our studied population was predominantly postmenopausal, ER-positive, HER2-negative disease with limited to 2 foci of disease in the breast and node-negative. A couple of the factors we've identified that may impact local recurrence include the use of a preoperative breast MRI to evaluate for the extent of disease prior to surgery, and the use of adjuvant endocrine therapy for those patients with ER-positive breast cancer. Overall, it's exciting to see that breast-conserving therapy is a reasonable consideration in multiple ipsilateral breast cancer. I'd like to thank the patients that participated in the study, the providers, coordinators, and in the institutions, as well as the NCI for the funding. Thank you very much.
Okay, we'll start with one of the online questions. Several people have asked which quadrants were these foci in, and was oncoplasty allowed and what type?
So oncoplastic surgery was allowed, any type, whatever the breast surgeon or the collaborating plastic surgeon wished to participate in. And in terms of the quadrants, we have not looked at specifically which quadrants the tumors were limited to, but it did require that there was disease in no more than 2 quadrants of the breast.
Thank you so much. And then in person, we'll start on the left with microphone number 1. Please identify yourself.
Hi, Evangelia Razis from Greece. I wanted to know if DCIS affected the rate of recurrence, or did you look at that?
We have not specifically compared those patients that had invasive and DCIS with those that had pure invasive.
Thank you.
And microphone 2. Or microphone 3.
Mark Baslik, Montreal. Judy, how many of these patients were really multicentric, or perhaps a surrogate way, how many of them had 2 separate incisions during surgery? And my next question would be, would you consider this for a neoadjuvant study?
Thank you, Mark. Excellent question. So in terms of definitions of multicentric, multifocal, we specifically stayed away from that because of the challenges that a lesion at 11:30 and a lesion at 12:30 would be 2 separate quadrants, even if they were within a centimeter of each other. So we pretty much stayed with that broad definition of multiple ipsilateral, requiring that 2 centimeters of normal tissue between the separate foci. In terms of the approach, about 30% of patients had a single lumpectomy approach, and about 70% of patients had a 2 separate lumpectomy approach. And there was no difference in local recurrence based on that.
And we have time for one more question. Microphone number 4.
Hi, Dan Hayes, University of Michigan. I have a comment and a question. I'm a medical oncologist, but I think it's fair to say that Drs. Veronese and Fisher would be very proud of you and pleased with the results you showed today. The second, though, is in the patients who had an MRI, how many patients were felt to have multifocal or multicentric disease before they had the MRI, or were actually detected by the MRI when it wasn't detected before it was done? Can you tell us that?
Yeah, so in the majority of patients, the workup was mammogram and or ultrasound followed by MRI. And if you look at that cohort of patients, in 58% of the patients, the mammogram and or ultrasound had identified all sites of disease, and the MRI did not add any additional value. In 42% of the patients, it was the MRI that identified the second and or third lesion.
And truly last question, microphone 6.
Vogel, New York. Another medical oncologist, thanking you for defining for us how we should look at a patient with 2 breast cancers. Do we multiply the likelihood that the patient will survive without distant metastases? Do we just do the larger one? I don't know how it figures out in your patient population, but it seems pretty clear that few of the patients got distant metastases. So multiplying the likelihood of survival will clearly give you a very high estimate of risk, way above what you observed. In the future, the people caring for such patients should feel fairly secure in reducing the chemotherapy, at least, for patients with low scores on the Oncotype DX or similar gene expression profiles. Thank you.
Thank you. Excellent comment. Yes, I mean, this was definitely a relatively low-risk population when you look at the tumor biology. Obviously, with excluding patients with neoadjuvant therapy, that resulted in this being a predominantly luminal breast cancer population, but it was very reassuring to see the low rates of distant recurrence as well as the low rates of local recurrence.
Thank you so much, Dr. Boughey.
Thank you.